Hey, everybody, welcome to the astr60 webinar focused on Biomea and its menin-inhibitor program. This is featuring Dr. Ralph DeFronzo, live from the 23rd World Congress on Insulin Resistance, Diabetes, and Cardiovascular Disease, WCIRDC. I was there about 2 years ago, loved it, great place, great presentation, great vibe. This is in Los Angeles, this presentation, that's where he's dialing in from. And then, of course, I'm here. This discussion will center on Biomea's positive 52 Phase II COVALENT-111 data evaluating icovamenib in patients with type 2 diabetes. I'll call it ICO, along with an overview of the mechanism of action of menin inhibitors as a potential non-chronic treatment option in diabetes. So, Dr. DeFronzo, welcome, and I'm just going to read out a quick presentation for you.
Make it quick.
No, absolutely.
Don't get too carried away.
Yeah, absolutely. I want to give everybody here a sense for why Dr. DeFronzo's perspective is so valuable. It's really important. I actually don't do this often when I give a lead-in to a key opinion leader, but for more than half a century, he's been one of the people who has actually shaped how we think about diabetes. Many of the ideas now that we take for granted, the role of insulin resistance, the multi-organ nature of type 2 disease, the need to intervene early and physiologically, trace back to a lot of the work that he has done, of course, with many collaborators. What's remarkable is that he didn't stop at defining the problem. He helped bring forward solutions that changed clinical practice, guiding the US development of metformin and later helping pioneer the SGLT2 inhibitor class by uncovering how the kidney handles glucose. These insights didn't just advance science, they rewrote treatment algorithms and improved outcomes for millions of patients. Across all of this, he's continued to mentor investigators, run large clinical programs, stay deeply engaged in the biology of the disease. When you talk to Dr. DeFronzo, as I've heard from other people also, he's been getting selfies, I guess, with people down there in Los Angeles. You get the sense that he still approaches diabetes with the curiosity of someone trying to solve it for the first time. So we're generally fortunate to have him today for his perspective, not just because of his accomplishments, but because of the way he connects decades of discovery to where the field is heading next. So Dr. DeFronzo, thank you so much for being here.
My pleasure. You're very, very kind in the introduction, but I appreciate it.
No, I really appreciate Dr. DeFronzo. So, to get to the meat of the matter, people here are dialed in. First and foremost, I know you did a presentation on menin down in Los Angeles at the present. Could you give us an overview of that and just sort of what are your takeaways from your presentation?
Yeah, the presentation actually was kind of a two-part presentation. One was to focus on the beta cells and beta cell failure and what we could do to improve beta cell function, and more importantly, to increase the number of beta cells, because we know with time there's a progressive loss of beta cells. And eventually, if you don't intervene with the appropriate therapy, you get to a point where you have a burnt out pancreas in terms of number of beta cells and beta cell function. So that's one half of the story. And the other half of the story was focusing on how insulin works and how tissues respond to insulin. So if we think about diabetes, and I would say really the largest perspective, either you don't make enough insulin or you don't respond to the insulin. Now, that's a really simplistic view, since I'm the person responsible for the ominous octet in terms of the pathogenesis of type 2 diabetes. But I think in terms of discussion points, if we just look at these two big problems, okay, how can I get people to respond to insulin? And number two, how can I improve beta cell function? And at some point in time, when you run out of beta cells, how can I increase the number of beta cells?
No, that's fantastic, Dr. DeFronzo. The role of menin in diabetes has been coming up more and more. When I was in Los Angeles 2 years ago, there were presentations there. If you can kind of give us a historical context, I know that menin was first discovered in pregnant women and how it works. But if you can give us a historical context and folks, who've also dialed in as to how menin fits in understanding the pathology of the disease and why it's a target, today versus like 10 or 20 years ago.
Yeah. Well, I think you already hit the most important thing. Menin in pregnancy, and women in the world should be thankful because of menin. So for a lady, when she becomes pregnant, during the second month of gestation, what happens is there's an incredible increase in energy needs of the developing fetus in the placenta. What happens is miraculously, the number of beta cells increases quite dramatically. So that's important to provide nourishment and energy in terms of substrates to be utilized by the developing fetus in the placenta. So how does that happen? So menin is an inhibitor of beta cell proliferation. It blocks beta cells from proliferating. Now, during the second trimester of pregnancy, as human placental lactogen goes up, that inhibits menin. So human placental lactogen up knocks menin down. When menin goes down, that's the block. That's blocking beta cell proliferation. So now in the mama's pancreas, there's an enormous proliferation of beta cells. This is a miracle. There's nothing else that will do this. And in fact, if this didn't happen, the developing fetus would stop developing. And then what's even more miraculous, because now you have all of these beta cells, all this insulin is being secreted. The mom delivers the baby, okay? If you have all of this insulin around, that's going to make your blood sugar very low and you become hypoglycemic. Well, now the menin levels come back up and that causes involution of the beta cells and the insulin levels go down. It's an incredible physiologic phenomena. And literally every one of us that's out there should thank their mom and the changes in menin for us being here. It's an interesting way to think about it, right?
No, absolutely, Dr. Franz. I never actually thought about that. And actually, that kind of leads me to a question about pre-diabetes, for example, right? So in a certain level, at least on a metaphorical level, right, a person who's pre-diabetic has had a certain amount of loss of their beta cells, right? So we need to increase it to get them to be, to produce more insulin. So it's sort of metaphorically analogous to the pregnant woman with, her baby wanted to have more beta cells, right, to produce more insulin. So and I don't want to get ahead of ourselves, but would prediabetes be in the long run an area that ICO could tackle?
Yeah, I think that's not where we want to direct our attention because in the person who has prediabetes, and we've published very extensively on this, they have, even though they may have a small decrease in the number of beta cells, the amount of insulin they secrete is very, very high. And even when you go into the early diabetic stage, they're secreting lots and lots of insulin. The problem at this stage is they're not responding to the insulin. They're resistant to insulin. But what happens is now, as you become progressively more and more diabetic, now you start to see this big drop in beta cell mass. And now we have a real problem because now we have a decrease in beta cell mass. We don't have enough beta cells. We're not making enough insulin, and the body is very resistant to insulin. So that's why my lecture today was really two parts. Number one, when we look at people who have significant diabetes, they now have a deficiency of the number of beta cells, and they have a deficiency of insulin. But now let's say I could reproduce their beta cells, and now I give them back more beta cells. They're still fighting against this insulin resistance, and that's going to put a stress on even these newly generated beta cells, and that stress will cause them to fail. So even though we give them back more beta cells, which is critical, we got to start there, we need to relieve the insulin resistance. That's why in my talk today, as I introduced it, we're looking at two extremes. Why did Dr. Yehuda Amelsman ask me to talk about both of these things? Sound very different, but they're very interrelated. You got to make enough insulin, means you have to have enough beta cells. You have to be able to respond to the insulin, and if either one is deranged, you have a problem.
Yep. And that's, Dr. Franzo, diabetes is one of the areas that I'm less familiar with, and I'm not a PhD or MD by training, so I have to do a lot of work, when I'm focusing on a disease. So if you don't mind, we might just spend a few moments, if you can kind of expound a little bit on specific, let's say, terminology that Biomea has used, physicians, diabetologists utilize, but I think will be also helpful. You talked about, for example, as you just did, the beta cell function versus beta cell mass, right? And just explain to us again, what is it with diabetics, the problems they have with beta cell function and the issues with beta cell mass, and how, menin inhibitors could help.
Yeah. So when you're born, you're not born with your full complement of beta cells. But within the first 2 years of life, your beta cells proliferate. And by year 2 of life, you've pretty much close got to your maximum number of beta cells. And then very shortly from year 2 to childhood, by the time you're adolescent, you no longer have beta cells that are able to proliferate. And so when you look at adults, your beta cells really don't respond as you would when you're 1 or 2 years of life into a number of stimuli. We'll talk about some of them, which would cause your beta cells to proliferate. So the problem is, if you're a quote pre-diabetic, this starts when you screwed up in choosing your parents. You got some bad genes. You can't get rid of these genes. So those genes are going to promote two things. They're going to promote something that causes beta cell failure with time, and they're also going to cause insulin resistance. Now, I'm a believer that in the majority, but not all, of people with type 2 diabetes, the earliest defect is insulin resistance. There are clearly another segment of people who present with early beta cell failure in the absence of insulin resistance. But I think the majority of people present with insulin resistance. And initially, in the pre-diabetic stage, they maintain normal glucose tolerance because their beta cells secrete lots of insulin. But then as they go from the pre-diabetic stage to the early diabetic stage, they're still secreting a lot of insulin, but relative to the level of insulin resistance, it's inadequate. And then as you continue to follow this person in life, their insulin secretion goes down. And there are two reasons for this. Because physiologically, the beta cells that are there are not working normally. And then the other big problem is you're losing the number of beta cells. So when you see people who, at the end stage of their sort of diabetic career, they end up on insulin. Why? Because their beta cells are either severely dysfunctional, or the bigger problem, they don't have enough beta cells. So later on, it's important that we have treatments. We don't want people to be on insulin therapy. It's very difficult. Personally, I think insulin in very, very high doses, particularly in obese people, is atherogenic. So I would prefer people not to be on insulin. I would prefer them to have their own beta cells secreting a normal amount of insulin and have their tissues responding to that normally. Well, unfortunately, when you have people who are not treated adequately, and about half of people in the United States and worldwide end up on insulin. So that means there are a lot of people who have gone through this sort of initial, okay, I make too much insulin to compensate for the insulin resistance, but now my beta cells are burned out. I'm not making enough insulin. And the real big problem is now I don't have enough beta cells. So I need to restore that. But now at the same time, I need to make their tissues more responsive to the insulin. So I got to attack both problems at the same time. And menin is one of these things which in the adult is blocking the ability of beta cells to proliferate. So if I had a way of knocking down menin, okay, maybe I could remove that block. I could remove that inhibition. And now that the beta cells that are there, they may not be functioning, but if I can get them now to proliferate and I can get them healthy again, I can get people off insulin. I can get them off their, anti-diabetic medications, their oral medications, or some of the injectable medications, because that makes it easier to treat our diabetic patients.
Yeah. That's fantastic, Dr. DeFronzo. I mean, it's like you've just distilled so much knowledge. I was kind of staying with you, but there's a lot there, which is fantastic that we're recording this. I'm sure for a lot of people, they'll want like the transcript and stuff. So, but one other concept I want to just ask you about before we actually dive into the data, from the COVALENT-111 study and what you thought about that, is this difference between insulin resistant, severe insulin deficiency. You've kind of explained about it already, but can you just explain what is it, that current medications, it seem like the approved medications seem to be really focused on this insulin resistance, phenotype. GLP-1s are making, beta cells perform better, et cetera, functionality, whereas insulin deficiency really is probably where there's a big unmet need. Am I correct there?
Yeah. Early in this quote pre-diabetic stage, I think the big problem is insulin resistance. But as I said, there are about 20% of the people actually who present early on with insulin deficiency. So we need to understand that diabetes is a heterogeneous disorder. But even though I think this is my personal opinion, and we've published a lot on this, so it's not sort of, hearsay or make believe. You are insulin resistant, say 80% of the people. Now that puts stress on my beta cells, and those beta cells, when they're stressed, they stop working, and eventually they die off. So now you're going to become insulin deficient. And then there's probably another 20% of people who start with insulin deficiency. And when you're insulin deficient and you don't have enough insulin, that leads to insulin resistance. Okay. So if you continue to follow diabetics on a long-term basis, they're all going to be insulin deficient and they're all going to be insulin resistant. And at some point in time, they're going to start to lose beta cells. And that is why, as I said, I think it's about 40 to 45% of people in the US and worldwide are treated with insulin. Insulin therapy is difficult. Why? You have to give, 2 or 3 injections of insulin. You have to, what we say, carb count. You need to know how many calories, how much carbohydrate in the food. So every time you have a meal, you have to take a short-acting, rapid insulin. You also have to take a bedtime insulin that works for 24 hours. You have to stick your finger 3 or 4 or 5 times a day, because every time you eat, you need to know where's your glucose. And then you have to say, based on where my glucose is and how much carbohydrate, how much insulin do I have to give? Now, of course, we've had breakthroughs. We have continuous glucose monitoring. So you can wear a little patch on your shoulder and it will read out the glucose. And maybe you don't have to stick your finger so much, but this is expensive and it's not available to everybody. So insulin therapy is not easy and it's expensive. And if you look at people who are treated with insulin, their level of glucose control, and we use the hemoglobin A1C to assess that, is always about 1 to 1.5 percentage points above people who are not using insulin. So why is that? Lots of reasons, but the most important one is insulin therapy is difficult. How much insulin do I need to give these 3 shots a day and the long-acting insulin throughout the day to control my glucose? That's not easy for patients to do. So it would be very nice for these people if we could give them back a sufficient number of beta cells, that their own beta cells that we've now regenerated for them would secrete the insulin, and it would take over the job of having these people to take an exogenous shot of insulin 3 or 4 times a day.
Yep. No, that's fantastic, Dr. DeFronzo. And I just want our listeners and everybody to keep an idea in their minds about this severe insulin deficiency, as Dr. DeFronzo has talked about, because we'll dive into that a little bit more once we've discussed the phase 2 results. And just on that, the COVALENT-111 study read out the phase 2 results, Dr. DeFronzo. If you can give us an overview of your thoughts on the results, pros, and if you saw any cons there also.
Yeah, so I'll try to simplify this. So there was a very large study several years ago from Sweden that divided diabetes into 5 phenotypes. And I don't want to get very technical about going into the 5 phenotypes. I just want to focus on 2 of the phenotypes because it emphasizes what I've been talking about. There's one of the phenotypes is the severe insulin deficient diabetes, SIDD. I'm not going to use the term SIDD. I will continue to use severe insulin deficient diabetes so that the listeners don't get confused. The second other large group are severe insulin resistance diabetes, the SIDS. So from a sort of large perspective, even though there are several other groups that we could talk about, I would like to just focus on these 2 groups. There is a molecule called icovamenib, which is a menin inhibitor. And so in this study, they basically phenotyped the individuals. And how do you phenotype them? Okay, you can measure the fasting insulin and you can measure the fasting glucose. And if you know the hemoglobin A1C and age, you can predict who are the people who are the severe insulin deficient type, who are the people who are the severe insulin resistant type. And their hypothesis was that if I treat you with a menin inhibitor, okay, uh, a pregnant lady, human placental lactogen goes up, it inhibits menin, menin goes down, beta cells proliferate, okay? So what I want to do now is I want to take these groups, let's just focus on the two groups, and I'm going to treat them with a menin inhibitor, icovamenib. And my postulate is, uh, behind the study, is that the people who are the severe insulin deficient, by allowing now the menin inhibitor, okay, to sort of deep repress the beta cell proliferation, your beta cells will proliferate, you'll make more insulin, and those people will respond very well. The people who are insulin resistant, okay, they should also respond, okay, uh, but the icovamenib is not an insulin sensitizing drug. So yes, I'm going to make them make more insulin because they have more beta cells, but I'm not correcting the severe insulin resistance. So I'm going to see a benefit, but it's not going to be nearly as good as I see in the insulin deficient people. So what they did is they treated the people for 12 weeks, and then after 12 weeks, there's no treatment, and then we follow them up for 26 weeks. So literally for 14 weeks, they're getting no treatment. So what happened was that in the severe insulin deficient group, they saw a very nice drop in the hemoglobin A1C, which is the index we use of glycemic control, of about 1.4 to 1.5, which is truly outstanding. Uh, so, as they predicted, you would expect that this group who has insulin deficiency, who's probably don't have enough beta cells, if I give them a drug that will cause beta cell proliferation, now that's of course something you can't be measuring. You can't be sticking a needle in the pancreas and measuring the number of beta cells. But I can look at the end product, which is how much insulin comes out, okay? And they did by measuring C-peptide, and they saw in this group there was a nice jump up in C-peptide, and that the increase in C-peptide correlated very nicely with the drop in A1C. So now let's take a look at the insulin resistant group, okay? So I'm going to give them, again, the icovamenib. What that's going to do is the same thing as in the insulin deficient group, but the problem there, yeah, maybe I make them make some more insulin, but they're so severely insulin resistant that even though they're making more insulin, I'm not going to be able to overcome the insulin resistance. So what did they see in that group? They saw a drop in the A1C was still good, 0.4 to 0.5. But as I said earlier, if you don't get rid of the insulin resistance, and the only thing I do is make you make more insulin, you have a problem, okay? Uh, so I'm a big believer in combination therapy. I've been saying this forever and ever and ever. In fact, to me, I've been saying this for 10, 15 years. Finally, in 2024, the American Diabetes Association finally made a statement that you should, quote, consider. That was the wrong word. It shouldn't be, you should consider combination therapy with an insulin sensitizer and insulin secretagogue. You should use combination therapy. But anyway, that's a step forward based on a lot of the work that we've done. So it's very clear that, in my opinion anyway, that the severely insulin deficient people are going to respond very, very well to the menin inhibitor, whereas the insulin resistant people, they are responding. They probably are proliferating their beta cells. They probably are making more insulin, but you're running up against the wall, and the wall is the insulin resistance. And I got to knock down the wall. And if I were to knock down the wall, like giving an insulin sensitizing drug such as pioglitazone, which I like, then you'll be able to now see, even in that group, the benefit of the menin inhibition.
Yep. No,
Hopefully
Dr.
that's
Franzo, again, fantastic stuff. I mean, it's so much information, and you sort of condense it so well. Very few wasted words. Really fantastic. But there are a couple of questions that seem to have come out of the call that Biomea did. With on sort of their covalent 111. I was wondering if I could ask you that on the efficacy side. Well, one is the patient population. So they're going to go off this severe insulin deficient patient. I imagine that the phase two, they're going to have to start running, the inclusion exclusion criteria will be set up in such a way, the protocols to be able to find these patients, right? How confident are you that they can find, quote unquote, find the patients that did well in the study, reliably, well, and consistently in a phase two study over many centers?
yeah. Well, I think you've hit on a very important question, and this is at the heart of the therapy. Obviously, if you want to get the maximum benefit, we need to identify the group who are insulin deficient. Now, remember that the group who are insulin resistant, they're also going to respond, okay, in terms of making more insulin and maybe having beta cell proliferation. But I'm not attacking the insulin resistance in that group. So that's a problem. But in the insulin deficient group, where that's the major problem, that's the group where I expect to see the biggest benefit. Now, we have very sophisticated ways of measuring how well your beta cells are working and how much insulin you're making. And one simple way is to do an oral glucose tolerance test and to measure how much insulin C-peptide you make during the oral glucose tolerance test. Now, in general, people everywhere in the world, endocrine diabetes societies, have gone away from the oral glucose tolerance test. And that is also, quite frankly, cumbersome for doctors in practice. Doctors are seeing patients every 10 to 15 minutes. They can't be doing OGTTs and measuring insulin and C-peptide. It's cumbersome, it's expensive, etc. But if you could, it would be very easy to identify the people who are the insulin deficient versus the insulin resistant. But it's not practical. So can we come up with a simple way of identifying who are the insulin deficient people? Well, from the studies that they've done now in the initial covalent studies, you can get a pretty good idea who are the people who are insulin deficient, okay? These are the people who are younger in age. These are the people who are lean. These are the people who have higher A1C. So you can use some relatively simple, phenotypic and laboratory features that we have in all of our patients. And then those are the people that are going to respond in the best. And in fact, in the studies that they've already carried out, where they actually have made sophisticated measures of insulin secretion, they know these are the insulin deficient people, and they say, who are they? Oh, they're much younger. Okay, look, these are people very poorly controlled. They have very high A1Cs. So we can come up with some pretty simple criteria. These are the lean people, all right? And so the hope is that as they go forward, that in the larger studies that they'll be carrying out, using these criteria, they can differentiate who's likely to be the insulin deficient people versus who are likely to be the insulin resistant people. And that I think they'll be able to do it. But we'll see for sure as we go forward how predictive these simple phenotypic and laboratory measures are in identifying the insulin deficient versus the insulin resistant people. Now, I want to point out that even though you are insulin resistant, and I said this before, I say it again, you are going to get some response. It's just not going to be as dramatic as in the insulin deficient. But here is even more important. Even those insulin resistant people, with time, because their beta cells are stressed, they're going to become insulin deficient. So maybe today they're not in the insulin deficient category. Wait 3 or 4 or 5 years, they will be in the insulin deficient category. And then now they'll have a much better response, okay? But you're still going to have a drug in those people that ameliorates the insulin resistance. People need to understand two big things with diabetes. You don't make enough insulin, you don't respond. I'm not going into the ominous octet and discuss about the other six factors. I'd like to keep this in the most simplistic way as we go forward.
No, that's great, Dr. DeFronzo. And then just going, it seems like when the company focused on the insulin deficient, patients, they had a pretty good, size effect of therapy, right?
Very
I think
impressive.
1.2, 1.4, 1.6, percent decrease. And this is with patients that are on background therapy, which I always found impressive. So these patients are already on, taking drugs that are pretty approved drugs that are pretty potent to begin with.
Yeah.
One other question, would be that still, these are small numbers. You've done a lot of clinical trials. You've been involved with a lot of drug development, in diabetes space. How confident are you that these small numbers of patients in this well-run trial, the COVALENT-111, can be replicated in a larger trial consistently, assuming they find those insulin deficient patients reliably?
Well, that's why we do these large trials. So we're going to answer that question. So in their studies, they found that about 20 to 25% of the total population were these severely insulin resistant individuals. And they, as I said, using some very simple laboratory and phenotypic values, were able to identify these people. I think this will bear out in the large prospective studies. I mean, we're hypothesizing, uh, but I'm pretty positive that it's going to work out. The good thing is we're doing a really well-designed study, or the company is doing a really well-designed study that will, I think, give a definitive answer to this question. And if it turns out that they are correct, that you can identify these people easily, that makes it very easy for physicians. They don't have to do an oral glucose tolerance test and measure the insulin and C-peptide. They just need to know, look, what's the BMI? That's simple. We have that in everybody. What's your A1C? Is it markedly elevated? What's your age, et cetera, et cetera, et cetera. And then we can say, these are the people who should really be placed on the drug. But then I would say, if you're really smart as you go forward, there should be another study in which now I'm going to give the menin inhibitor plus an insulin sensitizer, pioglitazone. I'm going to attack those people who are insulin resistant. And now, even though I may not have seen the menin inhibitor alone working in that group, now when I get rid of the insulin resistance, believe me, their beta cells are still not working, okay? And they got a deficiency of beta cells. Now I can see the benefit of my therapy. So I'm not giving up on the insulin resistant part of the people. But if you don't understand the pathophysiology, if you have a wall, okay, why you run against the wall? You're going to hit your head, right? And then you're going to get a bruise. So let me knock down the wall, and now I can run right through it with the menin inhibitor. So if you understand the pathophysiology, it goes beyond just identifying those severely insulin deficient people.
Yep. Great, Dr. DeFronzo. And I think that, Ramses and the team are also hoping that, investors in the biotech space are going to be, get jazzed, over time. They already are, I believe, about Biomea, but even more so they have the ability to run these, more of these trials. No, fantastic, Dr. DeFronzo. Going to the combination therapy, it was so fascinating to me. I followed this company previously when I worked for a bank as a sell-side analyst, and I thought their approach was really, really intriguing. And, an oral therapy for people with diabetes, that could help the beta cell mass, increase in beta cell mass. And so therefore, helping them control their A1C. But like this GLP-1 data in combination, with the 10 patients, I thought was really fascinating. I think that their chief scientific officers previously said that if you give or you downregulate menin, you see increases from transcription basis, mRNA goes up, for GLP-1 and GLP receptor, the protein goes up. So it seems that the, scientific rationale is there. What are your thoughts on the data? I know it's a small number of patients. What are your thoughts on the data in the combination with GLP-1?
Yeah, so this is a nice novel observation and potentially very exciting. So GLP-1 receptor agonists, people forgot the original reason why they were developed, because of their powerful effect on the beta cell. Now, we've gotten sort of lost in the dark because now everybody's concerned about obesity, and these drugs are wonderful for making you lose weight. Now, in the United States, if you listen to the TV, you see Oprah in the morning. So Oprah started this big, and in front of our eyes, she shrunk down. And of course, what is Oprah doing? She's taking one of these GLP-1 receptor agonists. So everybody now is focused on GLP-1 and weight loss, which is, believe me, very important, okay? But we've lost track of the fact that the reason why GLP-1 receptor agonists were developed is because they have incredibly powerful effect to improve beta cell function. So now, if these menin inhibitors upregulate the GLP-1 receptor, okay, this means that the combination of a GLP-1 with a menin inhibitor would be a potentially a very, very powerful combination. And I know that they do have plans to do a study in humans to look at this combination in more detail. So using the menin inhibitor alone can turn out to be very good, but maybe putting it with a GLP-1 would be even better. And if they're really smart, then they put it with pioglitazone, and that's like a grand slam home run in the ninth inning. For those of you who follow baseball, it's walk off. You made it.
That's great, Dr. DeFronzo. Hopefully, you're a fan of the Los Angeles Dodgers, and you've made it twice in a row now. So,
Now, I have to say, I'm actually a fan of the Boston Red Sox, and
okay.
I could have signed with the Red Sox coming out of high school in 1960, and my father has never forgiven me for not doing that. But I'm
Well,
very happy with what I'm doing.
yeah, Dr. DeFronzo, I think that there's probably tens of thousands of diabetic patients that have probably thanked you, both to you directly and in their prayers and just their thoughts. So I think the bargain probably worked out. One question I have is, just on the GLP-1 combination use, what is your idea, Dr. DeFronzo, of like what kind of patients, like there's so many patients taking GLP-1 now, right, that come and see you. How would you be able to identify those patients that would be a good candidate for combination with icovamenib?
Easy, everybody.
Yeah.
So I'm a big believer in combination therapy. So if you at the Texas Diabetes Institute, which I direct, we see 10,000 unduplicated diabetic patients every year. And initial therapy in these people doesn't make any difference if your A1C is 6.5 or 15. Right now, you get triple therapy from the beginning. You get a GLP-1, you get pioglitazone. We use an SGLT2 inhibitor. That's our triple therapy combination from the beginning. We have lots of data showing that this is great therapy for lowering your A1C, protecting your heart, protecting your kidneys, liver, etc. But now, if we had, the menin inhibitors, that would be part of this combination therapy, particularly in those people who come to us who have really high A1C levels, because those people really have burnt out their pancreas, either dysfunctional or some combination of dysfunction and loss of ASL mass.
Yeah. And is there, Dr. Franzo, just because I think investors, will probably want to be, they get a little bit, persnickety, for lack of a better term, and I don't mean that. I mean, they've got their investments to protect. The thing is that I think, until the protocol is written up and we find out what exactly, like when you say all the GLP-1 patients, would you initially just want the patients you've just put on a GLP-1 and so therefore put them as a candidate into the study, or would it be patients who've been on GLP-1 for a while and you see their A1C starting to creep up? Where,
Yeah.
where would you be initially in that phase two?
So I would like to see the prospective data as they go forward, what kind of results they're going to get.
Right.
But let's assume they do the appropriate study and we see, we'll be able to define what groups are going to respond best to this kind of combination therapy. But if I saw a very robust response by putting the GLP-1, now remember, if I give you a GLP-1, you're going to see a good response, particularly
Right.
the new ones.
Right.
But now if I saw that an even better response in the group that has the icovamenib added, it may well be that you ought to be thinking about putting these two drugs together right at the very beginning. Now, obviously, where we go and who are the people who are going to use the drug in combination therapy, we need to see what's going to happen as we go forward with the studies that are already design. But I think that the studies will give us the insight that we need as to who are the people who should be being thinking about for the GLP-1 combination with the icovamenib. But let's see the results first. And then when we see the results, we'll have a better idea where to go.
Yeah. And Dr. DeFronzo, to go down your path of pioglitazone, I mean, I think that's just such a cool idea, and I believe pioglitazone is generic too, right? If I'm not mistaken.
In state of Texas, it's $5 a month.
Yeah, yeah. So actually, those
Not
combinations
bad.
from a patient perspective, it would be even more compelling, right? Because you're combining a branded drug with a generic drug.
Yeah.
Correct. Got it. No, that would be fantastic. It'll be great to see Biomea go down that path. Dr. Franzo, I guess my other just questions, I'm sort of now starting to run out of questions. So I'm going to ask you like sort of, final Jeopardy, but these are more relaxed, easygoing questions. Let's just say we're a year or 2 years from now. We were back at this conference. I really enjoyed the conference, so hopefully I'll be there in person the next time we talk, and we'll be doing this via live conference call. But what clinical results would you like to see in the monotherapy, severe insulin deficient, that would be okay versus great? And then I'll ask you the same question. What would you like to see in the combination with GLP-1? But let's talk, what kind of results would you like to see 2 years from now that would be okay, that you think it's great to move forward to phase 3? And what kind of results, combination of variables would you just like, wow, Hartaj, this is actually pretty amazing?
Yeah. So I would like to see them reproduce what they've seen in the early covalent studies. So I'd like to see that using their criteria to identify the insulin deficient people, I'd like to see a nice drop in A1C of 1.5, which is, pretty similar. If it's better than 1.5, hallelujah. And that's in people who are starting with an A1C in the 8 to 8.5 range, which means that I'm going to get you to an A1C of 7 or less, which is the treatment goal from the American Diabetes Association. So that would be a fantastic response. As I said, the problem is identifying the benefit in the insulin-resistant people because they are so insulin resistant. Now, I know as they go forward, they're thinking about combining GLP-1 with icovamenib. And that is a study that really needs to be done. And so we'll see what the results are. And my guess is that we'll see an even better response in the insulin deficient group. How much better response in the insulin resistant group, I don't know. But what I'd also like to see done is the study where now they're combining, the menin-inhibitor with an insulin sensitizer. And then when they do that, then I think they'll see a blockbuster response in the insulin resistant group. Because once I knock down the wall and get rid of the insulin resistant, then they're going to see all of the benefit. Now, one of the big things that's holding back, I call it the big sort of known in type 2 diabetes, is that we do not have a way of measuring beta cell mass in people, real live people walking around. And that is really unfortunate. There is no PET isotope technology that allows us to quantitate beta cell mass. But if we had such a technology, then we wouldn't have to be worrying about, using A1C and body mass index and other things to identify who are the people who are going to respond. We'd be able to tell you definitively these people have, lost the great majority of the beta cells. These people have not. These are the people who you should go after. Unfortunately, we don't have that. So from the research standpoint, it would be very nice if someone would come up with such a tool. And then a lot of the things that we're kind of, quote, speculating on, which we will get an answer to in these studies, we could a priori feel much more comfortable knowing, look, I give the drug here. I can forget about measuring insulin. I can do that. But now I said, look, I doubled my beta cell mass. I just hit a home run.
Yeah, no, Dr. DeFronzo, that's great. One very specific technical question I have now that we're getting to the end was just in your thoughts there is that, one of in the study, there was some variability that was dependent on the PK, off the drug, right? And the area underneath the curve. And so here
Yeah.
we're gonna have to just get a little technical. And so, it seems like arm B, which was the 100 milligram, for 12 weeks QD, did better than other dosing regimens. And the company, figured out that was because of the area underneath the curve, the PK. How confident are you that in the future phase twos, this PK variability is not something that will, come to sort of bite, icovamenib. I know they're doing a food study, et cetera, and you've done a lot of diabetes trials again, but just what are your thoughts there? Does that raise any concern for you or not really?
I mean, of course, it raises a concern because there is some variability. So we need to be objective about this. And one of the things that you mentioned is that the interaction with food may be playing some important role here. So, yes, am I a little bit concerned? Yes. Why am I less concerned? It's because they're doing the appropriate studies to look at what's causing the variability. So eventually they'll get a better handle on this, and then they'll have a better idea about going forward, use with food, without food. So although I am concerned about the variability, I feel very comfortable that they have the appropriate, studies that are being done actually as we speak to define what is causing this variability. And then once they have identified this, I think they'll be able to markedly reduce this variability.
Yep. And Dr. Franz, I want to ask you another question. It's just a much more bigger picture question. Get your thoughts there. And again, I don't know this space, as well as maybe some others. But you had mentioned earlier about how beta cell mass, we can't stick something into the pancreas to like measure beta cells, right? The amount of beta cells. But you also mentioned at another time that we have ways to tell where a patient's beta cell mass is and how well they're functioning, right? We're sort of surrogate measures for lack of another term, right? We've got various diagnostics and tools that in diabetes that you can have. How confident are you that in the future, there's a possibility of some of these tools becoming, or these endpoints becoming, I know H1 is like a surrogate marker that could, help speed development along, right? I know that H1, A1C is already a sort of a surrogate marker, right? But could there, for icovamenib, which specifically is impacting beta cell mass, right? Are there surrogate markers that you think could speed the development, not just for the initial studies, but maybe for studies down the road?
Yeah. This is a big problem, as I said. It's the big unidentified question. We don't have a good measure of beta cell mass. And it would be very nice that the people who are working, as I said, with these PET technologies, that they could come up with such a technique. That would then simplify everything. And there are a lot of people, there are some people in Sweden who have some, I think, interesting leads. So you have to have a molecule, a peptide, that is only present on the beta cell. So now I can make a radiolabel tag that will interact only with that molecule, and that molecule is only present on the beta cell. So now I can give the antibody, it will bind to that protein on the beta cell, and then because it's radiolabeled, I can pick it up with PET. So there are people who are working on this technology, but I have to say it's not been an easy nut to crack, or we would have had it by now. Yes, I think we will get this technology in these tools. When I can't give you a definitive answer to that, but you can rest assured we'll be one of the first groups that are using the technology to really look at this question of beta cell mass versus function in much more detail.
Yep, great, Dr. Franzo. And then, I guess last couple of questions here. One is that are you going to be one of the sites in the phase two that is participating, that they're going to be running?
Well, I already told them that I would be delighted to participate in these studies. And we have a unique sort of advantage. As I told you, we see 10,000 unduplicated patients every year. And I just did an analysis at the Texas Diabetes Institute. 78% of our people are on GLP-1 receptor agonist. For their GLP-1 study, they don't need to go to any other sites. We can do the
Right.
whole study in San Antonio, okay? Uh, I'm hopeful that we will be one of the sites, particularly in the GLP-1 study they are planning.
Yep. And then, just another thought on just again thinking a little bit, out of the box and big picture. Assuming investors who are interested in diabetes, give Biomea, the ability to fund more studies. I mean, could a investigator-sponsored trial be done, for example, with icovamenib and pioglitazone? Would that be a study that, for example, your site would be willing to entertain if the financing was available?
I would start the study tomorrow. To me, this should be done at the top of the list, and I give you the answer in a year, and we wouldn't be sitting here speculating because I think this study would show that even in the insulin resistant group, who are not, they have they have a good response, it's just not as good as the other group, we would give you the answer very quickly.
Yep. And then last question, just on type 1 diabetes, Dr. DeFronzo. Any thoughts on icovamenib in type 1 diabetes, or you think that's still over the horizon and maybe something, to think about down the road?
No, I think, of course, the jackpot is type 2 because it's right here. But
Right.
I think type 1 is a huge unmet need. And so as part of my presentation today, I talked about other molecules that would also cause beta cell proliferation. So in type 1, there are two problems. Problem number one is these people have no beta cells. So we got to find some beta cells. We
Right.
don't have enough people in terms of who pass away, they're going to donate their pancreas. That's never going to work. So now, with things like icovamenib and several of the other molecules I talked about today, in a test tube, we can actually cause these beta cells to proliferate. So now the availability of beta cells is not going to be a problem. I'm quite concerned about this, all right? But in type 1s, now you have the immune response. So now, yes, I have the beta cells and I can give them, but I'm still going to have to suppress the immune response. So I would say that these molecules, and there are a number of totally different classes than menin inhibitors that can expand beta cell mass. That will be a way to get around step number one. I have enough beta cells. Step number two, we still have this big problem of immunosuppression. And, Tecumseh, we have some new drugs that look promising, anti-thymocyte lymphocyte globulin, maybe giving the beta cells with GLP-1 with the immunosuppressive therapy right from the beginning. So I think that this is not so far off. I think it's on the horizon, quite frankly, and needs to be pursued. This type 1 diabetes is a big problem.
Yeah.
And even though, there are all these, I call them gadgets and, artificial pancreas, etc., uh, it would be very nice if people had their own beta cells and they didn't have to wear a pump and they didn't have to worry about constantly measuring the glucose and they could just go on and do their everyday life and be really normal and not have to be thinking about this.
Yeah, no, absolutely well said, Dr. DeFronzo. I can tell you I've done hundreds of these. This was a real pleasure. Thank you so much for taking your time. I know you're very busy there, for having this amazing energy. Ramsey's told me about it, and it is absolutely, you're spot on. Your energy is amazing, and your insights are great, and the amount of care you have for your patients also shines through. So really, thank you so very much, Dr. DeFronzo. Really a pleasure, and look forward to many more conversations.
Okay, anytime you want. It was great talking with you. You have a good rest of your day.
Thanks. You too, Dr. DeFronzo. Have a good one, everyone.
Bye bye. Ciao,
Bye-bye.
ciao.